My first encounter with health inequalities was just when I was 8 years old. I remember losing a childhood friend to neurologic complications of a measles outbreak in Haiti. As a little girl, I could not comprehend that my siblings and I had survived because we were vaccinated, while this child, with whom I used to play and who lived in the same neighborhood, had died because she wasn't. Later, during my pediatric residency, I had the opportunity to do a rotation at the oncology department of a big hospital in Montreal. I couldn't help but noticing the differences between the broad range of therapies available there and how limited the care was back home, as our patients didn't have access to second or third line treatments. I painfully realized that cancer survival really depended on which country you were living in. This lit a fire in me, especially since my father had just been diagnosed with cancer. Now, this is a man who loves his country more than anything, but who had to make the difficult decision of leaving his home, his family, and take advantage of that green card that he was fortunate to hold to move to the United States so he could increase his chances of survival. It became evident to me that health inequality was the root of everything that was wrong with this world. Imagine things like unlawfully immigration to more developed countries could stop if people had access to basic human rights like healthcare, education, a roof over their head, which are all determinants of health, no matter their background or their socioeconomic status. As a young physician, I became aware of the importance of fighting for more equitable access to healthcare and other basic needs for all my patients. When Chris and Rick, two extraordinary American physicians volunteering in Haiti, saw how difficult juvenile diabetes was to diagnose and to treat in the country, they didn't hesitate and founded Kai Mackensen Clinic, a center that would provide free diagnosis and assist Haitian children with type 1 diabetes in their day-to-day management of the disease. They vowed for the organization to make a huge difference in the lives of young Haitians struggling with the cost and the burden of diabetic care in Haiti. And in fact, it is making a difference in a country where more than half of the population lives below poverty level. And unlike many non-for-profit organizations, they made sure that whoever would lead this institution would be rooted in Haiti so that person could understand the unique reality and challenges of living in a country like Haiti. But to borrow from Dr. Wen's nothing short but amazing keynote speech yesterday, sometimes what my patients are going through and what they need from me is not something I can help them with inside of the clinic. To assess long-term glycemic control in diabetic patients, we track glycated hemoglobin level, which reflects the average level of blood glucose over the course of the previous 3 months. This is done to monitor the overall efficacy of the treatment and of their management of the disease, with the aim of reducing risks for early complication so difficult to handle in a country like Haiti. But at the clinic, despite all of our efforts, despite the free insulin and the free supplies, 97 of our patients kept showing poor glucose control. So I decided to take a closer look to understand what was happening. Liz is a 15-year-old adolescent, very smart, with age-appropriate grade level, which is something quite uncommon in Haiti, you'd be surprised. Needless to say that our expectations of her diabetes management were understandably high, and she delivered. Since she was having great numbers, I decided to see her again after 3 months instead of 1. But on her next appointment, she arrived in clinic with horrifying weight loss and shortness of breath. Liz, what happened? Haven't you been taking your insulin? Why didn't you call me? I asked in disbelief. The insulin we give you for free, I thought in my head. She bowed her head in shame. She told me that her single mom had lost her job and could no longer care for their family of 6. They would spend days without being able to afford a proper meal. So since she was not eating, she decided to stop taking her insulin to avoid hypoglycemia. Ruth is also a 15-year-old adolescent whose parents, 2 busy vendors, thought their only child being diabetic was just a curse from the neighbors who envied their business and how flourishing it was. They didn't really believe in the diagnosis and showed their daughter very little attention. She felt unseen, unheard, and she was so depressed that she decided to commit suicide. When I talked to her about it, she told me that frankly, her parents could actually afford the insulin we were giving for free. But what she really lacked at home was emotional support. Someone to show her that she mattered. Someone to help her get through the distress associated with her diagnosis. These stories helped me realize that we needed to make drastic changes in the way we were caring for our patients by getting rid of the one-size-fits-all approach. Having one-on-one conversations with each of them enabled us to understand their individual needs and address those specifically. This way, we identified the ones with greater socioeconomic distress, and we're looking for ways to help them being able to afford a proper nutrition, which is key to diabetes care. We also identified the ones in greatest need of emotional support, because mental health is taboo in Haiti. People don't talk about it. People don't want to see a provider. People don't seek for counseling. And it's our duty to help them understand that it's okay. It's okay to feel this way. You're living with a disease that is chronic, that you have to manage on a daily basis. It's okay to need help and to get that help. You deserve it. So by going the extra mile, we want to make sure that we help our patients achieve better glycemic control and better overall well-being, no matter their socioeconomic status. So going back to the thought that sometimes what my patients need from me cannot necessarily be done inside of the clinic, as it's often not medically related, I say, why not? Why not use my workplace with my stethoscope around my neck to treat them, but also to advocate for them, to educate them, to teach them, and to connect them with the right people that can help meet their other needs, even if they're not medically related. This fellowship program gave me a voice, a fuel, the fuel I needed to leave my comfort zone and make things happen. It pushed me to question the status quo and helped shift my perspective on vulnerability. From being considered a weakness, this quality I think I have is now my greatest asset. This fellowship taught me the true meaning of many hands make light work. It forced me to identify allies, like-minded people who were as hungry as I was to move things forward and help make me advance with my project. I am now a better leader, a better communicator, a better physician, mother, and even wife, because of how, over the course of this year, this program has shaped me, and I'm forever grateful. Thank you.